Good morning, good afternoon, good evening, everyone. Welcome to our non-communicable disease talk series. Should I try again, sir? Good morning, good afternoon, and good evening, everyone. Welcome to one of our first non-communicable diseases talk series. In this session today, we'll be discussing the topic of transforming public health through strategic taxation. This session is co-organized by the sector departments of Public Sector Management and also Human Social Development of Asian Development Bank. This webinar is in collaboration with Asia Pacific Tax Hub and the Center for Global Development. We will have a series of key presentations today, as well as a summary of Task Force Fiscal and Policy for Health report, the Philippines' experience on health taxes, and a series of ADB work on excise tax policies by the Asia Pacific Hub. Without further ado, I would start first with the welcome remarks by our Director Eduardo Banzon of Health Practice Team of the ADB. Eduardo,
Okay.
please.
Thank you, Vas. And first of all, thank you for everyone who's finding time to listen to our discussions on strategic use of taxation to pursue public health goods, to pursue universal health coverage. I'm privileged that among our speakers here is a former finance secretary of the Philippines, to whom, when I was still in the government of the Philippines with PhilHealth, we all worked together in getting the sin taxes increase in the Philippines and get that to fund universal health coverage. I think since then, 13, 14 years since then, we have seen a lot of countries pursue this, and this has now proceeded, of course, beyond the usual suspect of tobacco and alcohol. So, thank you for everyone for listening. And we look forward to supporting our developing member countries in Asia and the Pacific. Look into this as a source, as an innovative source of financing for universal health coverage, and also as a tool in achieving good health outcomes. So over to you, Vas.
Thank you very much. So now we're going to go into the official part of the program. Yes, I haven't introduced myself. My name was Suntara Priksawan. I'm working with Dr. Eduardo's office, and my work is mainly on primary healthcare and NCD. So it's really a pleasure today to actually introduce the panel. So one thing I would like to do with housekeeping is if you have any questions, please feel free to leave the notes in the chat, and then we'll come back either the speakers will address it directly, or we will bring back at the end at the questions and answers section. So first, I'd like to introduce our first speaker and panel who will be introducing the studies. So we have Mr. Pete Baker, who is the Deputy Director of the Global Health Policy Program at the Center for Global Development. Mr. Baker is a public health specialist and a fellow at the UK Faculty of Public Health. Without further ado, Mr. Baker, if you'd like to come up online now, please. The floor is yours. Thank you.
Thank you very much, Vas. Thank you, Dodo, and thanks to ADB for hosting this session. So indeed, I'm Pete Baker. I'm the Deputy Director of the Health Programme at CGD, and we were privileged to be the Secretariat for this high-level task force on fiscal policies for health. Next slide, please. So this task force was originally convened in 2018, and its first report in 2019 concluded that health taxes were really a very effective measure of improving health, but also raising money for other social expenditure. And they were found broadly to be underutilized around the world, with some examples of success like the Philippines, but otherwise not used as much as they could. We then reconvened the task force in 2024 to look at progress over those last 5 years, and also to try and regain the initiative that was perhaps lost during the COVID pandemic. Our second objective was to try and make the case that the current fiscal and economic crisis that the world is going through made health taxes an even more relevant policy option. We brought together a range of experts and policymakers from the finance, health and development community, including, of course, Cesar Prisma, who's here today, 3 former prime ministers, two ministers of health and 4 ministers of finance. And they reviewed the evidence and produced the final recommendations that Mr. Prisma will provide to you in the next session. It was chaired by Mia Motley, Mike Bloomberg, and Larry Summers, and we produced the final report in 2024 with 4 background papers, including produced by some of the colleagues here today. Next slide, please. You can look online at the exact makeup of the task force, so I won't take up your time for that. So let's go on to the next slide, please. But I guess I just want to make a final case that when we produced the report, we had our minds on the post-COVID slow economic growth, on the increase in debt and increased interest repayments that were causing such a debt crisis around the world, and how health taxes were so important in that context. But actually, of course, times have changed, as we all know, and there's another important ingredient to consider. There's been steep cuts to international aid, not just from the US, but in fact from pretty much all of the G7 countries now, that are either hitting countries today or will do in the next couple of years. Probably the weight of this has fallen on Africa, but also a substantial weight of this is also falling on Asia. We took a look at 26 countries that were not only the most hit by these aid cuts, but also were unlikely to be able to fill those aid cuts because of a limited domestic capacity to raise taxes. And you can see that in the blog there. Most of those are in Africa, but 4 countries, Afghanistan, Laos, Myanmar, and Bangladesh, all, of course, covered by ADB and received more than 10% of their government health expenditure from aid, and were therefore quite exposed to the current aid cuts. But perhaps more worrying in the Asian context may be that donors may withdraw additional funding from the Asian context and prioritize Africa instead. And so I think domestic resource mobilization is really, well, it always was the key answer, of course, to health financing, but it's ever more so important. And health taxes, as we'll talk about today, are a great way to raise money for that, but also a way to do so without harming the economy. So without any further time taken up by myself, I'd like to introduce Mr. Cesar Prisma, who is the former Secretary of Finance for the Philippines, but also, very importantly today, a former chair of the ADB board. So over to you, Mr. Prisma, to highlight the findings in your report. Thank you. Next slide, please.
Thank you, Peter, and good afternoon.
Next slide, please. Sorry, I forgot that slide.
Yeah. Okay, first slide. Can you go back? There. Good afternoon, everyone. Thank you for having me here today. It's a privilege to speak to you about the policy tool that is often overlooked, but that we believe is one of the most powerful levers we have in tackling the converging crises we face: health, fiscal, and development. I'm referring to health taxes. Today, I'll be walking you through the findings of the Task Force on Fiscal Policy for Health, whose mission is to champion the smart use of fiscal tools like taxes on tobacco, alcohol, and sugary beverages to save lives, raise revenue, and promote equity. Next slide, please. The work I'll be presenting is from the most recent report from the Task Force on Fiscal Policy for Health, released last September. This body brings together global experts from finance, health, and development, and is supported by the Bloomberg philanthropies. Our aim is simple: to make the case for health taxes not just as health policy, but a smart economic policy. The full report, along with supporting materials, is publicly available at the link on the screen. Next slide, please. Let's begin with the problem we're trying to solve. We're witnessing a rising tide of non-communicable diseases like heart disease, diabetes, and cancer, largely driven by preventable risk factors like smoking, alcohol use, and excessive sugar consumption. The COVID-19 pandemic didn't help. It disrupted routine care for these conditions and left millions more vulnerable. Today, these risk factors account for a growing share of deaths and economic loss worldwide. Next slide, please. By 2030, non-communicable diseases will account for 75% of all deaths globally. And the economic toll is staggering. an estimated over $4 trillion annually in direct and indirect cost. While smoking rates have dropped slightly in percentage terms, the absolute number of smokers has continued to rise. There are still more than 1 billion global smokers, resulting in roughly 8 million annual deaths. Alcohol use saw declines before COVID, but has since rebounded. There were 2.6 million premature deaths caused by alcohol in 2019. The good news is that alcohol use is dropping in some areas, but Southeast Asia and the Western Pacific region saw substantial increases in alcohol consumption between 2000 and 2019. Meanwhile, the consumption of sugary drinks is climbing steadily, especially in sub-Sahara Africa. A 16% increase in sugary beverage consumption since 1990 has contributed to more than a billion people living with obesity. In short, we are on a fast track towards a preventable public health crisis unless we act decisively. Next slide, please. But this isn't just a health issue, it's a fiscal issue too. The pandemic pushed many governments into emergency spending, leading to unsustainable debt burdens. Today, 60% of low-income countries are in or at risk of debt distress. Shockingly, 3.3 billion people live in countries that spend more on debt interest than on health or education. In many parts of the world, government spending in 2027 is projected to be lower than it was in 2019, raising the specter of a lost decade for development. Next slide, please. Despite the urgency, momentum on health taxes has stalled since 2019. Only a handful of countries have raised cigarette taxes meaningfully. Alarmingly, in 87% of countries, cigarettes are now as affordable or even more affordable than they were in 2016. Alcohol taxes are being used less as a fiscal tool. And while many countries have passed sugary drink taxes, the rates are often too low to change behavior. Even where taxes exist, inflation is steadily eroding the real impact. Next slide, please. Here's the good news. We know what works. Let me walk you through the highlights. Next slide. Raising health taxes to achieve a 50% increase in product prices could generate 3.7 trillion in just 5 years, with over 1 trillion from East Asia and the Pacific alone. If even a part of this were channeled into health, it could increase government health budgets globally by 12% and by 40% in low and middle income countries. And that's massive and within reach. Next slide. Beyond revenue, health taxes save lives. A 50% price increase on tobacco, alcohol, and sugary drinks could prevent 50 million premature deaths over 50 years. That's 27 million from tobacco, 22 million from alcohol, and over 2 million from sugary drinks. Tobacco taxes in particular are the single most effective intervention, capable of driving over 100 million people or 10% of the world's smokers to quit. Next slide, please. Let me now shift to what's politically possible, and I'd like to offer the Philippines as a case study. Next slide, please. Since 2012, we've passed 4 major rounds of tobacco tax reform under 2 very different administrations. The 2012 sin tax law was particularly pivotal. It simplified our tax structure and mandated automatic annual increases to keep pace with inflation, protecting the real value of the tax. Next slide, please. What made it work is that we framed it as a health reform, not just as a revenue measure. That shifted public perception. We earmarked 85% of incremental revenues to health, funding universal health care. The remaining 15% went to support tobacco farmers, cushioning the blow. And we had strong interagency cooperation, especially between our finance and health ministries, backed by civil society and robust data, Bloomberg Philanthropies and ADB included. The results speak for themselves. Between 2012 and 2016, cigarette affordability dropped by 13%. Adult smoking prevalence declined from 30% in 2009 to 20% in 2021. Among the youth, it dropped from 18% to just 10%. So we didn't just pass legislation, we actually changed behavior. Next slide, please. The fiscal gains were just as striking. We nearly tripled the Department of Health's budget between 2012 and 2016. We expanded health insurance coverage. And from 2012 to 2022, excise revenue nearly tripled, rising from 0.3% to 0.7% of GDP. Next slide, please. And crucially, this isn't a partisan issue. Countries across the political spectrum have implemented health taxes. In fact, they often enjoy broad public support, including among users of these products, especially when people see the revenue going to health or education. So this is about smart policy, not partisan ideology. Next slide, please. But let's be honest, industry opposition is fierce. Tobacco, alcohol, and beverage companies are well-resourced and deeply entrenched. Governments need to show sustained political will. That means framing the issue around health, mobilizing coalitions of support, communicating proactively and strategically, and enacting safeguards to protect policy making from industry influence. Next slides, please. To sum up, here's what we recommend countries should do. Raise health taxes significantly, especially tobacco taxes. Design taxes to increase prices above inflation, making these products less affordable over time. Counter industry opposition with evidence, public support, and policy coherence. Reduce subsidies and advertising for harmful products. And tap into the technical and financial support available from institutions like the IMF, the World Bank, WHO, ADB, and regional development banks. For multilaterals, the call is clear. Use every opportunity, including fiscal policy dialogue, to promote stronger health taxation. In closing, let me leave you with this thought. Health taxes are not just good health policy, they're good economics. They're fiscally responsible, politically feasible, and profoundly impactful. In a world facing deep health and fiscal crisis, we need tools that are fast, fair, and effective. In our report, we have demonstrated how health taxes are one of the most effective in the policy toolkit. It's time governments use them to their full potential. Thank you, everyone, for listening.
GD and also from the insight from the Philippines case study from the team. In particular, the experience that we have seen an example of the Philippines is very insightful, and this could also be practical to other countries in the region. Thank you very much, Mr. Purisima. With this, I also want to point out that in the webinar chat, there's also the link from the details of the task force itself, which you can further investigate. The next part of the session, we'd like to introduce you to the ADB work on health taxes, and these are a series of 4 studies. With this, I would like to introduce our moderator for this particular section, Mr. Sandeep Bhattacharya, and he's a senior public management specialist at the ADB. Mr. Sandeep, please.
Hello, can you hear me? Hello?
Yes, all good. Please go ahead.
Oh, thank you so much. So we'd like to present 4 studies, as mentioned earlier, on health taxation. The first is a published study, which is an ADB knowledge product, and the genesis of that was a previous study done by ADB in 2012 that examined the role of potential taxes on tobacco in the 5 highest prevalence tobacco use countries within ADB. In fact, so we thought that with a lapse of 10 years or more, it would be nice to revisit that study and the conclusions and the suggestions from it and see to what extent these 5 countries, PRC, India, the Philippines, Thailand, and Vietnam, had actually implemented those policies and what the effects of these recommendations had been. So with that, we commissioned a knowledge product, which is published and available on the ADB website. The 2 primary authors of that, the 2 authors, in fact, of that knowledge product, Dr. Hannah Ross and Dr. Riju John, examined what the situation was in these countries 10 years on. So Dr. Hannah Ross is with us today to present this study.
Great, thank you. Thank you very much, Sandeep.
She received a PhD in...
Yep, go ahead.
Hello,
Yep.
can you hear me?
Yes.
Yes. So, and she is an honorary research associate at the University of Cape Town and senior research associate of the Vienna Institute for International Economic Studies. With that, I'll hand it over to her and request her to present the ADB knowledge.
Great. Thank you very much. Thank you very much, Sandeep, for the introduction and also for inviting me to talk at this important webinar. So as Sandeep already explained, the motivation for the study, it was a repeat of a previous study 10 years later, just to see where these 5 countries, 5 high burden countries, are, or how we progress in terms of prevalence and also their tax policy. Next one, please. So as you know, Sandeep already explained, these are high burden countries. So in fact, 41% of all the worldwide smokers, about 401 million smokers live in these 5 countries. And the largest, the smoking prevalence ranges from about 23 in China to 8% in India. And even though India has a relatively low smoking prevalence, and the reason for that is a substantial consumption of smokeless tobacco, with that, even because of the size of the country, it actually has second most number of smokers after China. Next one. So we first look at the tax situation and how a tax burden evolved in these 5 countries over time from 2010 to 2020. We looked at the excise taxes that are levied per pack of the most sold brand. We used the local currency, but we adjusted it for inflation. So the meaningful comparison would be the percentage change, which is in the middle of this table. And there you see Philippines being very clearly the winner of this, where they increased their taxes, excise taxes, by 1,273%. And total taxes by almost 1,000%, so which is quite an incredible accomplishment. We have almost all countries on this list increase their taxes. But if you think that this is an increase over 10 years, that increase is not that impressive, especially in Vietnam, where the increase over 10 years in excise tax was less than 9%. Next one. So the next we looked at affordability of cigarettes. So affordability of cigarettes is looking at the prices that are relative to income, and affordability is measured as a relative income price, which is defined as percentage of per capita GDP necessary to purchase 100 packs of cigarettes. So in this graph, the higher the slope, the better, meaning less affordable the cigarettes are. India is very clearly a country with the least affordable cigarettes, but as I already mentioned, their consumption there is mostly focused on smokeless tobacco, and cigarettes are considered to be more or less a luxury. So in the other countries, when we see the development over time, the Philippines, again, is very clearly increased the slope, meaning reduced the affordability of cigarettes substantially over the 10 years. In other free countries, China, Thailand, and Vietnam, the affordability is either stagnating or, in fact, in case of Vietnam, improving. The slope is declining, therefore the affordability of cigarettes increased substantially in Vietnam. Next one. So, and then we look at the smoking prevalence. Here, the most meaningful would be the last two lines of this table, where you see how the overall prevalence changed over time and the number of smokers. So, comparing to the global standard or global metrics, where the global prevalence between 2010 and 2020 declined by over 19%, here we see was a similar decline in Philippines, quite a substantial decline in India, and again, maybe this is reflecting the luxury nature, but also the development of India over those 10 years. And the slowest decline in prevalence was in China and in Vietnam. In terms of number of smokers, this metric is related not only to prevalence, but also to population growth. So we see that even though in the Philippines, the prevalence declined substantially, the number of smokers in fact increased a little bit, and this is primarily because of the population growth. In Vietnam, the increase in number of smokers is driven by both population growth and a lack of evidence-based excise tax policy on cigarettes. Next one. This table is focusing on revenues. So here you see how the revenue, both excise and total, increased over time. All countries increased their revenue in real terms over time, except for Vietnam. Here in fact, the real revenue from cigarettes declined over time, over the last 10 years, which is quite a shame. We see the best performing country here, Philippines, thanks to their excise tax reform. The other countries, Thailand it was a little bit of disappointment for us. We believe that Thailand had a reasonable excise tax policy, but here you can see the increase in revenue was, in excise tax revenue in real terms was less than 5%. And we believe that's because of the Thai tobacco monopoly is manipulating prices and possibly engaging in some tax avoidance practices. Next one. So once we took a stock of the situation, we used a tax simulation model to see what is possible. And so we modeled two scenarios, one when the prevalence would decline by 5%, and the other scenario was such that the prevalence in tobacco, the cigarette use would decline by 10%. We used standard simulation model where we looked at prevalence, size of population, the volume of the market, and we also look at the price and cigarette prices and what they consist of. We look at the production cost, the taxes levied, but also industry profit. Next one. I also have a slide on input in terms of price elasticities, but I can be happy to share it with you, or you can also go online and look at this report. But here is the summary table for the tax simulation model. The first column for each country is 5% reduction in prevalence. The other one is 10% reduction in prevalence. Very clearly, 10% reduction in prevalence would be more beneficial not only for public health in terms of reducing the number of smokers, life saved, but also for excise tax revenue. In some cases, like China, would really extremely benefit. Their revenue gain can be more than 3,000%. They have a really huge potential there to increase their tax revenue from cigarettes. In other countries too, especially Vietnam, again, huge potential to increase tax revenue. And so the revenue gain was quite substantially in all cases, even with the reduction of prevalence and consumption levels. Next one. So here I'm going to summarize the results of the model, because the previous table had the results in local currency units. So we added up all the gains across these 5 countries for a model that looked at the 10% reduction in cigarette use prevalence. And there we see that 10% increase in reduction in prevalence would result in almost 40 million fewer smokers in these 5 countries. It would prevent close to 12 million premature deaths, and at the same time raised over $67 billion. There will be additional tax revenue. So you can imagine that it will be quite substantial boost to these 5 countries. So in a conclusion, overall, over the 10 years, there has been limited progress in tax policy in China, India, Thailand, and Vietnam. In the Philippines, the progress was very much visible from this analysis. There was quite successful excise tax policy change. But we see that it's still not the time to quit, even for the Philippines, because we can see that cigarettes are quite cheap and affordable. So there's even in the Philippines, the tax can still increase further. And based on the model, we saw that significant increases in excise taxes would lead to price increases, but also substantial public health gains, as well as the economic and revenue gains. So next one, I think that's the last. Yes, that's the end of it. So thank you very much. You can type in your questions in the chat box. Thank you.
Thank you very much, Hannah, for the presentation. And if there are any questions, please do type them in the chat box, and we'll make sure that you have an answer. And if we have time at the end of the program, we'll do a few selected Q&A. So the next study is not a published study. It is a report, a technical assistance report that ADB, jointly with the World Health Organization, produced for the ASEAN Secretariat on tobacco taxes in the ASEAN region. And one of the interesting questions that once came up while presenting these studies is there's a fundamental tension between the Ministry of Finance and Ministry of Health, in that if these taxes were to be truly successful, you have to plan for the revenue disappearing from this source at some point, as happens with carbon taxes in the Nordic countries, for example. So ASEAN member states account for over 13% of the world's adult cigarette smokers, and high youth tobacco use poses a risk for health and productivity. Now, there's an estimated 13.7 million people across ASEAN countries can stop smoking over the next 7 years, depending on the tobacco policies being adopted. And this study, as I mentioned, was conducted jointly with the World Health Organization. And from the ADB side, Dr. Rajiv Cherukapalli was the consultant who wrote this study. He has a PhD from Columbia University and an MA from the Delhi School of Economics, and is currently an economist at Johns Hopkins University's Bloomberg School of Public Health. And he has a long history one more time. Dr.
Thank you, Sandeep, for that introduction. And if someone could tell me if I'm cutting out, that'll help, because sometimes my audio cuts out. Thanks so much for setting the stage, and it's great to be following Hannah in the sequence of presentations. So rather than spend too much of time going into how our model worked, I might just spend about the next 5 to 10 minutes giving a little bit of more of a context for how we did, how we came up with the model that we came up with, and where we felt it met a strategic need. Next slide, please. Great. So starting with Secretary Purisima, I think our job here, and if you're attending, you're probably always interfacing with policymakers at some point or the other. I think we should be sure, and we should be convinced amongst ourselves that tobacco taxes absolutely work. We really need to move the agenda much forward, and we are at a stage in the world where our job really is to help policymakers choose well. So in this context, just to give the context for where our model came in, there was a strategic opportunity in 2023 with ADB helping with the ASEAN's Excise Tax Forum, and as part of several intergovernmental organization conversations. And the universal theme that comes up is of tobacco taxes being an excellent health and financing tool, but policymakers always requiring a little bit of additional assistance, a little bit of thinking in what sort of targets we should be setting. So one of the things that you might come up when coming up with a model is this tension between how ambitious we should be in suggesting a target to a policymaker and how realistic we should be in terms of the real policy environment of the country. But the one underscoring theme that I'd like to make here is that we really do not have the time to reinvent the wheel, and we do not have the need to reinvent the wheel, because there is a highly well-developed literature in economics, in public health, and in public finance that talks about the effectiveness of taxes. There is a large evidence base that we can use, and there is excellent data that we can use if we just search around a little bit. Next slide, please. So in the spirit of saving time for the policymaker, let me jump to our conclusion. We concluded that accelerating prevalence declines in the 10 ASEAN countries was certainly possible, would lead over 7 years to 13.7 million fewer smokers, and would raise taxes substantially in every country in the region, with the amount by which taxes raised depending on where countries started from. Next slide, please. So the context here is that we were able to come up with a set of recommendations and a model in a fairly short time. And we submitted our report in December 2023, and we were able to present it in a forum in March of 2024. So just in terms of the key elements of this kind of exercise, when you're asked to generate numbers or a model on short notice, one, we wanted to take a very quick, rapid assessment of why we were doing this and what the situational summary in the ASEAN region was. Two, we wanted to put a little bit of effort and thinking into our model in consultation with everybody else, including Sandeep, on what our parameters should be and how ambitious or not we should be. And three, we wanted to come up with a set of recommendations that would appeal to everyone, but that would also be as data-driven as possible. Next slide, please. I would be remiss there if I didn't point out that much of the modeling work is done by my colleague Lara Russo, who's a good friend and colleague of Hannah Ross's as well. And the conclusion, in the first few weeks that she and I were looking at the literature, we knew from firsthand that there are high rates of adult tobacco use in the region. It is a region where in the ASEAN region, countries with relatively high prevalence, relatively high adult prevalence, and especially important for health and for future human capital formation, youth prevalence tends to be in the sorts of ranges that would make public health folks uncomfortable. Countries where you see 20% of children starting to smoke or being attracted to some sort of tobacco product is not a trend that you'd like to see in the longer term. And it's something that prices certainly can, higher prices can certainly stop that take up and that future trend. Next slide, please. In terms of the other quick situational data that we had based on the data we had access to at WHO and reports that I worked on in the past and Laura and I had familiarity with, we could easily conclude that cigarette prices have increased over time, something that Hannah also pointed out, but have stagnated in a lot of countries, partly as a result of their not having raised taxes over time. So that's one thing we could say, that prices have not increased appreciably in some countries, or certainly not as much as they could have. The one exception, again, relative to where it was in 2008 was the Philippines, and that's the upward sloping green graph that you see. Next slide, please. So that happens to be, it's always a challenge to say, well, what should we target for? Ideally, you'd want cigarette prevalence, tobacco use prevalence to fall down all the way to zero, right? But that's not happening overnight. So there are recommendations out there. And one of the recommendations was, well, maybe by 2030, starting in 2015, countries thought, well, maybe we should be able to at least bring about a 30% relative reduction in cigarette use. That sounds fairly reasonable, 30% less prevalence of smokers. As it happens, some countries were actually on the path when come 2022. But a lot of countries were flagging in their effort or had stagnated. By 2022, it had become clear that even if we thought that countries should decline in prevalence from 2015 to 2030, Indonesia was actually on an upward trend, which is extremely concerning. Other countries have had a decline or are on trend. So Cambodia, for example, was on trend. But for the most part, even a place like Singapore, which we think of having a relatively strong tobacco control policy, has some way to go if they're trying to be ambitious about reducing prevalence relatively fast. Next slide, please. So we had this simple situational summary. And so then comes how we go about our modeling, right? So what I said, combining ambition and realism and being strategic about it. What could be greater than, what could be a greater opportunity than the fact that 10 countries are focused really on helping their populations and on using fiscal policies in the right way. Right? So there's a strategic exercise. There's a time constraint. We were asked to do this within 2 to 3 months. We wanted to keep it simple. We wanted to focus on the key drivers of death, in this case, cigarettes. So you may say, so we say tobacco taxes, but as a simple modeling choice, we had to choose cigarette taxes because that represented the largest burden of use in these 10 ASEAN countries. The other thing which I'd like to spend 1 second motivating you to think about is when you're doing a modeling exercise like this, we try to often work back from the end, right? And that's not a bad idea. So if you remember what Hannah talked about, their simulation was about 1 or 2 scenarios in which they were raising taxes and prices by 10%, 50%, and so on, and finding what the impact would be. Here, we kind of did the reverse exercise. We said, well, all countries do have this target of reducing their prevalence. They've not done that well, but what would they have to do in terms of raising their taxes and prices to get there? And finally, I cannot emphasize more messaging. And that's a hard lesson for those of us who are technically trained to learn. But we learned that especially when we work across fields or when we have to capture people's attention, we really need to keep our message simple. We do the homework, so at least we are consistent and we are comfortable with our assumptions and that how our model works. We have our peer reviewers, but we should be able to give that one little takeaway, which was you can save 13, or you can have 13.7 million people quit in the next 10 years with a massive boost in your revenue. So you policymaker, this is your chance. So next slide, please. So to build on how we came up with our targets, I think as I mentioned, there was this idea that over 15 years of time, at least, there should be a 30% reduction in prevalence. The fact that this did not happen told us that maybe countries need to be a little more realistic. So then we said, well, if you're already on the path to reducing consumption, and you're getting somewhere in 2030, let's try to make you a little more ambitious and get you 10% more, 10% further reduction than that. So that's how we came up with a modeling endpoint for what we wanted the fraction of people smoking in each of these countries to be that we proposed between the time 2023 through 2030. Next slide, please. And that's what this looks like. Well, it's a fairly simple straight line graph. So that tells you that we have our start point and our end point, and now we need to do something to get there. Next slide, please. What is that something? Like any demand model, so we raise prices in a certain way, which is through tobacco taxes, and that leads to a reduction in consumption. Either through the intensive margin or the extensive margin, which is the intensive margin, I smoke less. The extensive margin, some people quit and there are fewer smokers in the country, right? Both of which lead to a reduction in prevalence of smoking by the endpoint. The additional things that, because the quality of data that WHO has collected over the years has been so good, and we knew that that the ASEAN audience would know their countries well. The one thing we wanted to be aware of is that price policy are not the only factor, right? There are other tobacco control policies that have been affecting the trend. So we needed to be aware of the other sorts of things that reduce prevalence over time. We needed to remember that population growth would increase the market size, that income certainly plays a role, so that income elasticity comes into place, which is a big part of the reason why with increasing affluence, especially with the ASEAN region being the most dynamic economies in the world, it's a big part of the reason why price increases are absolutely important to bring down affordability. So some of these things we just kept in our mind, and we certainly took them in the background. Next slide, please. So the simple mechanics of this model are: we started with a baseline prevalence, including the sales of cigarettes in all of these countries, and we accounted for what the rate of increase in prices would need to be every year over a period of 7 years, accounting for inflation, accounting for prices, and we had a fairly good data on what the baseline prices were and how we could get there. Next slide, please. Just again, we had about 100. Our estimates were 123 million adult smokers to start with, and we assumed a 10% price increase reduces consumption by 2%. So that's our elasticity assumption in most of the middle income countries, or by 1.5% in the higher income countries, which in that region would have been Singapore and Brunei. So we computed the decline with the price increases necessary to bring about the declines, accounting for the annual inflation, which is in the range of 0.75 to 9+% in the countries, and a fairly robust GDP growth in all of these countries. Next slide, please. So essentially, this is the sorts of graphs that we were able to come up with, cranking through the data, which was that a consistent reduction in our desired reduction in prevalence, the blue dashed lines, could be brought about through an increase in prices consistently across those years. And when I say an increase in prices, I always mean an increase in real prices. So adjusting for inflation, adjusting for projected inflation, an increase in prices. And how would we get there? Through an increase in taxes, where we have a sense of what fraction of price taxes are and what they would end up being at the end of the 7-year period. Next slide, please. So this was our the kinds of prices that we model, and that's where we went through a reality check, which is, well, we are proposing that prices should rise to reduce consumption. Are they reasonable? And it turns out that a lot of these price increases are actually reasonable. That is, to achieve a decent decline over a 7-year period, you do have to raise prices, but the sorts of price increases are not the sort that would make a policymaker wonder whether the market is changing in a fundamental way. No, these are fairly reasonable increases in prices, especially when you remember that, to start with, tobacco products tend to be taxed more than most other products. Next slide, please. So our main conclusion was that it is possible to help 13.7 million, well, make that 13 million smokers quit across our countries in about 7 years. And next slide, please. And that there was a consistent increase in revenues that was accruing from these taxes. To Sandeep's point, that fear that policymakers sometimes have, that the benefits of raising taxes will disappear when prevalence declines or when consumption declines. That is a valid fear, but the fact that tobacco use is inelastic works in our favor. That is, there is quite a long time, certainly in the 7 to 10 year to even 20-year horizon that we think of for this region, where prices are low to start with. An increase in prices does not lead to a decrease in revenue over time, in tax revenue over time. If anything, every year saw an increase in prices, and by a multiple factor. And then next slide, please. I'm almost at my end. So, so the reality of what what our model findings were in terms of what it meant for the policymakers was, actually a lot of countries do fall short of best practice, whether it is in the structure of taxes or in terms of the levels of taxes, the things that Hannah talked about. Next slide, please. And so we were able to recommend that countries can achieve the targeted increases in prices by simplifying their tax structures and by working within that larger framework of the simple model that we used to advance tobacco tax policy in the ASEAN region. And that's it. Thank you. Next slide, please. Thanks again.
Thank you very much, Dr. Rajiv, for that presentation. And now we move quickly to the next one. This is a study we have completed, again, for the client being the ASEAN Secretariat. But this study was done jointly by ADB and Johns Hopkins University's Bloomberg School of Public Health. In fact, I should mention actually at this point that I really would like to thank our partner, Bloomberg Philanthropies, for funding many of these studies behind the scenes and for the support they have provided us for all our work. Even though they are not explicitly mentioned when it comes to receiving credit for the studies being done, they are a driving force behind quite a few of them. So our presenter here is Dr. Jeffrey Drope. He's a research professor at the Johns Hopkins Bloomberg School of Public Health and Director of Economics for Health. And he's the author, editor of 3 books and more than 200 research articles, chapters, and reports on the political economy of non-communicable diseases. So over to you, Dr. Drope.
Thanks so much, Sandeep, and thanks very much to the ADB for this opportunity to talk a little bit about
for the presentation of the alcohol taxes in the ASEAN region.
Thanks, Sandeep. Appreciate it very much for the invitation to be here today. I think this presentation is probably going to look quite a lot like both Rajiv and Hannah's presentations, except that the subject matter is alcohol, but we can see that there are a lot of parallels between these two product classes. Next slide, please. First question we always ask is why. So let's go to the next slide and figure out why. Really, one of the issues obviously is that alcohol consumption is large and widespread in many of the ASEAN countries, and the health harms from alcohol use are exceptionally well documented, both in terms of health harms, also in terms of social harms. And these contribute to enormous economic harms, both direct and indirect costs from using alcohol. And we're talking somewhere around 2% or more of GDP in terms of these economic harms, sometimes quite a lot higher in some of the high burden countries. And we know that excise taxes on alcoholic beverages, particularly spirits, are very low throughout the ASEAN region. And we also know that prices are very low. So with putting these together, we know that increasing the excise taxes on alcoholic beverages would increase these prices. We know that consumers are sensitive to price and they will decrease their consumption. So we would then see much less alcohol use, and then we would also see tax revenues increase because of the inelastic nature of these products. Next slide, please. This is just a really quick demonstration of what's going on in the world versus ASEAN. And the take-home point from these two, unfortunately, the scale is different on these two figures here. But the point is that the share of alcohol sold in ASEAN countries as a proportion of global sales has actually almost doubled in the space of 14 years. So it is one of the fastest growing alcohol markets in the world. So really something to consider here and to be concerned about in terms of its negative effects for society. Next slide, please. This is just a look at total per capita alcohol consumption for 15-year-olds and older. And you can see tremendous variation, and you can see some very high alcohol burden countries. Next slide, please. This is current alcohol drinkers by percentage, again, 15 years and older. And you can see that actually some of these numbers, well, first of all, some of the numbers are very, very high. But I think that when these numbers first came out, that a lot of countries were actually quite surprised. These are based on survey data that, in fact, the proportion of people who reported being alcohol consumers was much higher, I think, than many governments really first anticipated. So even comparing it back to the previous slide, where the actual alcohol consumption per capita is fairly low in some of these countries, what we do know is that it is growing, and that we know in particular that youth consumption is growing very, very quickly. Next slide, please. And next slide. Just going to talk a little bit about the methodology that we used. It was quite similar to the one that Rajiv already outlined for tobacco, except that we were using a slightly different target. We were using the Global Action Plan for Non-Communicable Disease from the World Health Organization. They originally had a 10% decrease in consumption by 2025 with a 2010 baseline. We modified it a little bit because it actually was made more ambitious subsequently and was raised to 20% consumption reduction, except it was extended to 2030. So we used that as our target, but we used 2023 as our baseline. So what we actually modeled was a look at, obviously, this 20% reduction. And then what we wanted to find out is what was the projected excise tax increase that we would need in order to obtain the price increase that we would need to obtain this 20% relative reduction. And then we were able to look and using these numbers to actually look at the projected excise tax revenue, because we were really quite interested in understanding what the implications for tax revenues would be. Next slide, please. We also looked at costs, and we used a fairly crude estimation of both indirect and direct costs. We've actually done some more sophisticated cost estimates, and we've actually found that our crude estimates are actually pretty close to our more refined estimates. But really, in a nutshell, we just looked at the DALYs attributable to alcohol use and multiplied it by GDP per capita, and then we based the direct costs off of some excellent work by our colleagues, Manthe et al., who really found that the direct costs are usually around half of the indirect costs. Next slide, please. We had some general assumptions. I won't get too deeply into them here, but 40% alcohol content for spirits, 5% for beer, and then we actually used ex-factory price as our base for all of the ad valorem excise taxes. We also included a profit margin, obviously, because we expect that companies are going to be seeking those. Most of the companies actually quite dominantly in the ASEAN region, we have really quite large corporations that are mainly responsible for selling alcoholic beverages. Next slide, please. Going to talk a little bit about the results here. You can see here, this is the excise tax. You can see in the second column there, it's the excise tax per liter in local currency at the baseline. And then in the next column to the right, you can see the required tax. And then we have the percent increase in the last column on the right. And so this really helps us to see that we need a fairly substantial increase in the excise tax on beer in order to reach our goal of the 20% decrease in consumption. And quite frankly, I know these numbers look really quite dramatic to probably everyone, but this really just has to do with the very, very low taxes that we observe in the region. So when you think about it in absolute terms, it's actually not that great, but the percentage increases do look quite dramatic. Next slide, please. This is just the same table here, except for spirits. And you can see that, in fact, the percent increases required for spirits are quite a bit lower. And this is, again, simply because of the actually significantly hard to, let me step back. The taxes are still low, except that the taxes on spirits are higher on average than the taxes on beer in most countries in the region. So you can see that the percentage increases are less. Next slide, please. These are the projected tax revenues on beer if we reach our goal of the 20% reduction and the required excise tax increase. And you can see that we have some really substantial tax revenue increases all across the board, some really quite dramatic increases. So you could see that there is a lot of potential to raise revenues that could then be allocated towards health spending. Next slide, please. Very similar story here for spirits, obviously not quite as dramatic in terms of revenue potential as beer, but still, nevertheless, certainly you can see that in several of the countries, there really is, again, significant revenue potential once we raise those excise taxes. Next slide, please. This is the total costs that we calculated using the very crude equation that I just shared with you and the tax increases that are required to recover them. So you can see that basically if we think about it from a Pagovian perspective, we're nowhere near recouping all of the costs of alcohol use in these countries, and that you can see that even in some of them that the amount of excise tax increase required to cover these costs is really quite substantial. So we really have a long way to go, and you can see that the amount of alcohol consumption is really a losing proposition economically in all of these countries. Next slide, please. So we definitely had some challenges in terms of these calculations. I just want to make the point that these are, fairly crude calculations done on an aggregate level using publicly available data. What we do in a lot of countries in which we work, including several ASEAN countries, is we actually refine these, and we work with ministries of finance using their data, and we're able to refine these calculations a great deal and give far more pinpointed estimates that I believe can be helpful for policymaking needs. Next slide, please. Again, this is just what I just said. Data. Sort of the crux of this. Good data help us make good forecasts. Next slide. And just to conclude, these are, of course, crude estimates, but we really see that the very clear take-home point is if we can raise prices via excise taxation in these countries, it's going to reap enormous rewards in terms of declining consumption and the health and social rewards that come from that. And then, of course, the enormous revenue potential for excise taxes in these countries. And I'll leave it there, and I thank you for your attention.
Thank you so much, Dr. Grob, for the wonderful presentation. And then now we come to the last study. This one is equally interesting, if a little different. The client here is the government of Indonesia, specifically the DG of Customs and Excise. And it actually was a study done to support a potential policy action in Sean's DRM PVL in Indonesia. This study was conducted by Dr. Krishna Gupta, who is a lecturer at Polytechnic APP Jakarta and a senior fellow at the Center for Indonesian Policy Studies. And it's especially interesting because just like in India, where Dr. Hannah Ross mentioned that there are different types of tobacco as well as different types of smoking products, Indonesia also has a product called kretek, which in addition to regular forms of cigarettes, and in fact, the policy implications of people switching from one type to the other were of interest in this particular case. So I'll hand it over to Dr. Gupta to please tell us about the work done in Indonesia on cross-price elasticity.
Hi everyone, thank you Sandeep for introduction. Great to be here, join you guys. So a little bit different. My study is a little bit detailed on Indonesian case. So I will share a little bit some information about Indonesia, but the main idea here is I want to estimate the elasticity of the taxes to consumption. I hope everyone can hear me clearly. Next slide, please. So the first thing I want to say is Indonesian excise structure is slightly more complicated compared to others. It's been notorious. There's a plenty of bracket based on what kind of cigarette you sell. And then based on the firm's production size as well. So there are some sort of a large numbers of combination. And this is because the Indonesian government have also, aside from the demand control of tobacco, also have a revenue generation target and jobs generation. So this particularly interesting to me because the government tries to limit the job loss from a shrinking industry because of the excise tax, and somehow the excise Director General of Indonesia somehow have to think about this as well. Next, please. Slide 3. So yeah, this this is some sort of the category. I probably have to explain a little bit. So the first two, the SKM and the SKM, is the kretek cigarette that Sandeep just mentioned. This is very Indonesian and have some strong cultural reference on the use of these cigarettes. And this is very popular in Indonesia. The SKM, the M part is machine. So the SKM is the kretek cigarette produced by a machine rolled. SPM, the SPM is the normal cigarette that non-Indonesians typically smoke. Again, the M is machine. And 1 and 2 is basically the size of production. If you're large firms that produce 3 billions or more, then you have to get, you will get some sort of a higher tax. And SKT is the kretek as well, but is hand rolled. So they don't use machine, not the automation kind of thing. So it's a slightly lower in productivity and employ more people. And as you can see here, the tariff for this SKT is lower because it employs more people. That's the idea behind this layering. So typically SPM is the most expensive, and the demand for this SPM is pretty negligible. It's really about SKM and SKT. That's the kretek is the most popular. I was trying to find out whether a higher taxes on SKM or SPM gives lower sort of demand, and actually they don't reduce demand. They just move to the different tier, either the same kind, same type, but a different production tier, or entirely move from machine to hand rolled. Next, please. Because of that, the data that I need needs to be quite extensive. Right. So yeah, the job goal tends to leads to a lower tax for the hand rolled. I would say that this goal actually may undermine the whole revenue goal and control goal that the excise want. Next, please. So yeah, so the data that I get is from the excise, from the government, actually. They they sort of lend me monthly data from 2014 to 2023. So the data is administrative. That is, this is the customs that's kind of collect this. Unfortunately, the bottom part, the SKMP is price. They kind of do some sort of a survey, the excise, but not as extensive as the rest. So I can't really get the data on each category precisely, as much as the other parts, like the quantity, the revenue, the tax, and the base price for the taxation. Everything is complete from January 2014 to December 2023, but the market price, because this is a survey data, and the excise don't really do a lot of survey between these years. So yeah, unfortunately, the sure regression and other types of estimation is pretty hard to be precise, especially because I want to show, I want to have a cross-price elasticity, which requires lots of, a degree of freedom, and 11 is just not enough. Next, please. So yeah, this is the market price, and the bottom two are the hand-rolled from small firms, right? And as you can see, the market price of these two really diverge compared to the other cigarettes, especially the expensive white cigarettes and the less expensive one, but machine rolled kretek. They start to climb, but really the hand rolled is really down there. Next, please. It's not even growing in price. And this is the best price. The base price is the price that the government used to tax, to put the tariffs. And the base price for the hand roll, the two least expensive, is really kind of flat. And as you can see in 2018 January, it actually went down. And yeah, it's raised up a little bit, but not much. So this is like the legal price. This is not a market price. Next, please. By legal, I mean that the price that the government used to tax. Okay, next. Sorry about that. And yeah, so this is the demand. And by demand, I mean really the quantity of the ribbon, excise ribbon that's sold to firms. And the top left is the kretek machine. Top right is the white machine, and the bottom left is the kretek hand rolled. And the bottom right is actually, I sort of have to add the three different types together. And as you can see, really, the hand rolled is dominating a little bit, right? It's even on the bottom right, it even chases the machine rolled kretek. And as you can see, the white cigarettes really don't go anywhere. It's very minuscule. So there seems to be movement from the machine rolled to the hand rolled. Next, please. This is a tariff revenue, so I'm gonna just skip this for now. But yeah, story is pretty similar. Next, please. Market price, as you can see on the bottom right, the three that I aggregated, the hand rolled really diverged, especially after COVID. The price is kind of flat, stagnated compared to the other two, the machine and white. Next, please. This is tariff per stick, and as you can see, the tariff per stick on the, let's go to the bottom right straight away. So the two, the white and the machine Kretek is going up and up per stick, whereas this is nominal price, by the way. I haven't deflated, but the hand rolled is really low, right? It's kind of makes sense to think that people just move this way, both firms and also consumers. Next, please. So yeah, this is basically what I said. Next, please. So yeah, probably the job is filled, the job goal, but so this one is a regression that I had to find from inflation data. So thankfully, the Indonesian Statistic Bureau have inflation data on three kind of cigarettes. The first one is filtered Kretek, typically machine rolled, and second one is the non-filtered, non-Kretek. So typically this is the expensive one, and the Kretek non-filtered, the LPK, the third one on the variables, that is typically hand rolled. I said typically because sometimes you have the machine rolled that's but unfiltered, and vice versa. But this is the best data that I can get from the BPS, the Indonesian Statistic Bureau, and there seems to be cross at least. Back to. Okay, cool. There seems to be a cross-price elasticity of around 5%. The first, the SKM, the first column is the quantity of the ribbon, excise ribbon. That seems to the number two is the white, the one that I kind of neglect a little bit. It's not so big in the market, and the last one is the hand rolled. So yeah, the price of the filtered seems to matter on the hand rolled. So that when the price of the filter go up, the hand rolled go up, and its own seems to be -5. So this looks makes sense, 5%, around 5% elasticity, but right, there's some assumption I had to make because of the data. So back to what Jeff said, right? The data really has to be extensive to have these cross price and own price elasticity calculation. So next, please. Oh yeah, and that is a box price. There's another caveat here. So BPS, the Statistic Bureau, collect box price, not per stick price, and there's no standard on how much sticks in one box typically. So yeah, this is another caveat that I have to mention. So I cannot say too much on the elasticity, unfortunately. And the data really is crucial. I need to work a little bit more extensive with them, so they can, and they need more time to probably make it to a machine readable data as well. So time is obviously needed here. And there's another e-cigarettes that's missing in my analysis. That the data is even less great compared to the traditional cigarette. So yeah, around 5% sounds plausible, but lots of caveats in there. So yeah, that's pretty much what I can say today. Back to you, Sandeep.
Okay, thank you all very much. We are more or less a little over time. We plan to stop at 5:15. I should also thank Dr. Drope for his contributions to the last study in Indonesia as well as Bloomberg Philanthropies, in addition to the work put in by Dr. Gupta. So thank you all for being here and presenting. I'll hand it back to our moderator, Vas, to close. Thank you.
Thank you very much for all the insights, all the presentations, and also for the participants as well. We've seen the webinar chats are very active. I actually have one question that was green out, and I know we're taking a bit of your time, but I just one question to the speaker, which I think we haven't addressed this. It's about SSB, the sugar sweetened beverage, and perhaps if you could one of that question answer of how to actually manage this in low and middle income countries, and I think this would also be very relevant to our next session as well. Maybe could I ask Hannah to jump in and just a brief answer, please. Thank you.
Great, thank you, Vas. Yeah, so there are several low-middle income countries already that have SSB tax, and what is the recommendation in order to make this collection of this tax the most effective is to use a specific tax per liter, volumetric specific tax, not base it on any value, and base it on volume. That's one advice. Make it relatively, and in fact, these taxes are not that difficult to collect because the markets are relatively concentrated. So you have your Coca-Colas, you have your Pepsi-Colas, you have few of these producers in a country usually, and so you tax at source and you tax volume. So, and in addition to that, it's also good to think about how to measure or make sure that the volume is correctly reported. And here it's about data, about requirements, reporting requirements by the companies to the government, to tax authorities, but also we can think about something like a flow meters that can measure actually the input of water to the factories and output in terms of SSBs. So there's a way to make the collection digitized, automatic, and also simple enough so that it can be collected. So we have seen examples, for example, in South Africa, where the collection, even though there's a little bit of a complication in assessing the amount of sugar in a beverage, and even that we were able to successfully collect a substantial amount of revenue, at least in the first couple of years before the industry reformulated the product. So that's another thing to consider. But it's possible to design a system, a tax policy that is then easier to collect, and tax collection can be quite effective. So thank you.
Thank you very much, Hannah. And I think there's a lot more that we can discuss also how different taxes work. And it's very helpful today that we learn from the alcohol to tobacco and also to SSB as well. So that links us to our next series. But just to thank everyone, all the speakers and all the participants, it's been very insightful for all the discussion. So we have the next NCD talk series coming up just in 2 days' time. And this is a really linking to type 2 diabetes. And we also have distinguished speakers. We hope that you can join us. We will distribute the same way without the link. And thank you very much and have a good afternoon, good evening, everyone. Thank you.